Dear audience, welcome to this symposium on stress sensitivity as a predictor of long-term vulnerability versus stress resilience. My name is Indira Tendolkar. I'm organizing this symposium and I'm working at the Dolcos Institute for Brain Cognition and Behavior and the Department of Psychiatry at the Radboud University Medical Center in Nijmegen, the Netherlands. Today, we actually have 4 speakers. First of all, you will hear a presentation of Florin Dolcos from the Beckman Institute in Urbana, Illinois, and he will talk about cultivating effective resilience, proof of principle evidence of translational benefits from a novel cognitive emotional training and intervention. Next, I will talk about childhood adversity that induces gray matter changes independent of psychiatric comorbidity. And then Shaozheng Quin from Beijing Normal University will talk about stress-induced neurocognitive reorganization linking to vulnerability from circuitry to network behavior. Finally, Fleur Duyser, also from the Dolcos Institute for Brain Cognition and Behavior, will talk about amygdala reactivity and negative memory bias, 2 stress-related vulnerability markers and their relationship in a naturalistic psychiatric patient sample. We hope that with this symposium, you will learn about the latest progress of innovative research in the field of stress vulnerability and resilience in clinical and non-clinical samples. We hope you will also learn of applications of multimodal brain imaging techniques and gain awareness and knowledge of multimodal brain imaging techniques and advanced analytic methods. In sum, we will give an overview of how the susceptibility to stressful life events play a role in the development of psychopathology in the shorter and longer term, also taking aspects of psychiatric comorbidity into account. I wish you a lot of pleasure, and now you can further listen to the other parts of this symposium.
Hello, and thank you for the opportunity to present some of my work here. Here is an outline. I'm going to first introduce anxiety as an epidemic. Then I'm going to talk about possible solutions to reduce anxiety through training interventions. And I will introduce the factors predicting resilience against anxiety and distress in general. And then I'm going to get into more details about an emotional regulation training program to increase resilience in student veterans. I will conclude my presentation with the summary and future directions. Over the past few years, anxiety has become the #1 reason college students seek counseling, to the extent that we can talk about an epidemic of anxiety. And of course, the existing elevated level of anxiety and distress are exacerbated by the COVID-19 pandemic. But this situation goes beyond the college students. Only in America, there are 40 million people suffering from different types of anxiety disorders. And these are associated with high costs, and not only related to anxiety, but also related to other symptoms of distress, such as depression. Now, what can we do about this? One possibility is to have training programs or intervention studies to investigate how we can enhance the brain and change the behavior or change the personality. In doing so, we can capitalize on the brain's plasticity, and we can investigate functional changes and also structural changes as a result of implementing different training programs. But let's get a little bit into some basic details about what predicts resilience and provides protection against symptoms of distress. In recent work from our group, we found that factors associated with regions linked to control, together with factors of personality related to different emotional regulation strategies, such as reappraisal, provide protection against symptoms of distress, such as anxiety and depression. And this has led to a so-called brain personality symptom model of anxiety, in which we indeed found that factors of control reflected in the thickness of gray matter in specific brain regions, together with factors of resilience, provide protection against anxiety, which has led to the idea that if we can change some of these factors, either at the level of the brain or at the level of personality, then we can increase resilience and reduce symptoms of distress, such as anxiety. But what else provides protection against distress? Another factor that we have identified as a possible personality mechanism in reducing distress is self-efficacy. That is the belief that we can withstand challenges and overcome challenges in the face of adversity that provides protection against symptoms of anxiety. In our program, we have different training interventions, and they all share this basic experimental design, where the training itself or the intervention is preceded and followed by assessments at the brain level, the neuropsychological level, the clinical level. And we have experimental groups and control groups. Here I'm going to focus on our so-called STRIVE training program in student veterans. But why student veterans? We were particularly interested in this population because they face specific challenges, such as related to fitting in. They are typically older and more mature, and they might have challenges in integrating with a typical younger student population. And they also might feel rusty because they have a break from their education. And in some instances, they might need to learn to manage their disability. And therefore, these different sources of distress can pose important challenges in student veterans. And of course, their experiences are also different from those of typical students. While typical students might socialize in a context like this, veteran students socialize during training or when they get to get a little bit of rest. And while this might be something that typical students are doing, in a case of veterans, they might carry the burden of their losses. Then we came up with a study that specifically was designed to target student veterans. And for this, we were interested in participants with a deployment assignment to Iraq and or Afghanistan in the preceding 5 years. And they were assigned to 2 alternative training programs over 5 to 8 weeks. And one of them, which is going to be the focus of the present talk, is focused on emotion regulation training. And we also use the control condition targeting broad social emotional skills. We particularly targeted 2 emotion regulation strategies, namely focused attention and cognitive reappraisal. Why? Because it's not enough to just have training in one emotion regulation strategy. So it's important to identify something that works at different levels of processing. So for instance, in a case of attentional deployment, it's relatively faster, and it can be well complemented with reframing or reappraisal, which is relatively slower. Now, while there has been a lot of evidence related to the effectiveness of cognitive reappraisal as an emotion regulation strategy, more recently, we and others have also provided evidence about the effectiveness of focused attention. Focused attention involves shifts in attention on or away from the emotional aspects of eliciting stimuli or events. And it's interesting that it can be deployed not only to focus on or away from the emotional content with external stimuli, but also with internal stimuli coming from memory. So for instance, you might look away from the scene of an accident in order to reduce the emotional impact. And at the same time, you can do the same on the mental image of retrieved memory of such a scene of an accident, where, for instance, instead of focusing on aspects that are the most emotional, one might focus on other non-emotional contextual details, such as whether the people present there were policemen or firefighters. And in doing so, it is expected that there is a reduction in the emotional impact of such events or stimuli. And it was also essential before implementing in a training to provide evidence for focused attention as an effective emotional regulation strategy, and also looking at both behavioral and brain mechanisms. Based on investigating focused attention with both external and internal stimuli, we found that focusing away from the emotional content was associated with reduced emotional response. For instance, here, there was reduced emotional experiencing of memories for negative events. A similar reduction in the emotional response, in the emotional ratings, was also found when focusing away from the emotional content of external stimuli. Related to these behavioral effects, we also showed evidence for the effectiveness of focused attention at the brain level. The engagement of focused attention to focus on non-emotional aspects and contextual aspects of stimuli and events was associated with increased response in cognitive control regions such as medial PFC and dorsolateral prefrontal cortical areas. And coupled with this, we found decreased emotional response in emotion processing regions such as the amygdala. This provides evidence of effectiveness when dealing with both internal and external stimuli in both cases. Now, how could we implement this at the level of a training intervention? What we did was to have focused attention and reappraisal engage with both internal events and external events. And this is just an illustration of how these two emotion regulation strategies were used in such contexts. At the same time, we also implemented a gradual training from basic training where participants got used to using these different emotion regulation strategies with different time perspectives. Then in a second module, we also trained flexibility so that they could flexibly engage different emotion regulation strategies depending on the needs, which culminated with a final module where participants learned how to use these different emotion regulation strategies to reduce the impact of possible future scenarios. And here are some results. At the behavioral level, we found evidence from improved executive function following emotion control training. As you can see here, there was a reduction in a reaction time in working memory tasks, consistent with an improvement at the executive level. Moreover, we've also found evidence for increased self-efficacy following emotion regulation training. And in both cases, at the level of improvements in the executive function and at the level of improvements in self-efficacy, we had specificity related to the emotion regulation training. At the level of the brain, we also found evidence for changes in the resting state functional connectivity as a result of the emotion regulation training. Just to orient you a little bit, the blue lines indicate decreases in a functional connectivity, whereas red lines indicate enhancements in a functional connectivity as a result of the training. Also, double lines, such as this between the amygdala and the medial frontal areas, indicate that there was such a change, in this case, a reduction in the functional connectivity as a result of the training in both groups, whereas solid lines indicate that the changes were specific or stronger in a case of the emotion regulation training group. Overall, this evidence is consistent with reduced bottom-up influences from emotion processing and perceptual areas, coupled with increased crosstalk among regions associated with cognitive control as a result of the emotion regulation training. To summarize, our emotion regulation training provides evidence that such intervention is promising in providing tools that allow adaptive changes of both behavior and brain. And such changes affect both specific and general aspects of processing. Interestingly, on a side note, these are also the factors that we have identified as being essential in providing protection against symptoms of distress during the COVID pandemic. In future research, we will further explore mechanisms of change at both behavior and brain levels. And we will also extend the effectiveness in other groups. I would like to conclude by acknowledging the contribution of many, many people, and also all the agencies that provided financial support for our research. And thank you very much.
Dear audience, it is my honor and pleasure to present here at this annual OHBM meeting in our symposium, Stress Sensitivity as a Predictor of Long-Term Vulnerability versus Stress Resilience. I'm Indira Tendolkar from the Dolcos Institute of Brain Cognition and Behavior, and I will talk about how childhood adversity induces gray matter changes independent of psychiatric comorbidity. But before I do so, please note that I do not have anything to disclose. There are significant relationships between adverse life events, psychosocial resources, and well-being. The general consensus is that adversities occurring early in life can have a profound influence on behavioral, emotional, physical, and cognitive functioning, leading to greater vulnerability for psychopathology. The experience of childhood trauma seems to foster several structural and functional brain responses as it hits the developing brain. As such, it is not surprising that extensive changes in adults can be found in gray matter volume in various regions of interest, such as the amygdala, hippocampus, insula, caudate, orbitofrontal cortex, and so on, when compared to controls with no history of adverse childhood experiences. This slide shows the structural results of a study by Dolcos and colleagues. 148 healthy subjects were enrolled via public notices and newspaper announcement and were carefully screened for psychiatric disorders. Amygdala responsiveness was measured by means of functional magnetic resonance imaging and an emotional phase matching paradigm, particularly designed to activate the amygdala in response to threat-related phases. Voxel-based morphometry was used to study morphological alterations. Childhood maltreatment was assessed by the 25-item Childhood Trauma Questionnaire. The CTQ. A strong association of the CTQ scores with amygdala responsiveness to threat-related facial expression was found. The morphometric analysis yielded reduced gray matter volume in the hippocampus, insula, orbitofrontal cortex, anterior cingulate gyrus, and caudate in subjects with high CTQ scores. Recently, it has been suggested that different types of adverse childhood experiences may lead to distinct morphological alterations in the brain, possibly corresponding to different types of psychopathology in adulthood. The authors used MRI-based cortical thickness analysis in 51 medical healthy adult women to test whether different forms of childhood abuse were associated with cortical thinning in areas critical to the perception and processing of specific behavior implicated in the type of abuse. Exposure to childhood sexual abuse was specifically associated with pronounced cortical thinning in the genital representation field of the primary somatosensory cortex. In contrast, emotional abuse was associated with cortical thinning in regions relevant to self-awareness and self-evaluation. Neuroplasticity during development appears to result in cortical adaptation that may shield a child from sensory processing of the specific abusive experience by altering cortical representation fields in a regionally high specific manner. Such plastic reorganization may be protective for the child living under abusive conditions, but it may underlie the development of behavioral problems such as sexual dysfunction later in life. It was proposed that a distinction could also be made between adversity in the form of deprivation, such as, for example, the absence of expected social input, and direct threat. These two types of adversities potentially lead to different neural outcomes. Deprivation, for example, could lead to changes in the association cortex involved in higher cognitive and social processes, whereas abuse could give rise to alterations in circuits involved in emotional learning. Indeed, a recent study by Everard and colleagues in healthy young males showed significant decrease in gray matter volume in subjects with a history of deprivation versus those with a history of abuse in the fusiform gyrus and middle occipital gyrus. The question, however, is how such findings change along the psychopathological continuum. Only a few studies have systematically investigated the impact of childhood adversity on different sorts of psychopathology. In this study by Friesen and colleagues, traumatic childhood events such as emotional neglect, psychological, physical, and sexual abuse was assessed using a questionnaire in a sample of 252 adult psychiatric patients with no psychotic or bipolar disorder and no cognitive disorders as main diagnosis. Patients were diagnosed for DSM and Axis 1 and 2 disorders using structural clinical interview. This allowed for the assessment of comorbidity between disorders. The results indicate that childhood trauma may be of importance for a broader spectrum of psychiatric diagnosis besides the frequently studied affective disorders. Importantly, frequently experienced traumatic events during childhood increases the risk of comorbid psychiatric disorders. In the light of the aforementioned studies, we think what is missing is investigate the relationship between childhood adversity, psychiatric comorbidity, and changes in brain structure by directly comparing healthy subjects and psychiatric patients with different disorders. Therefore, we propose to take this approach starting with regions of interest that may have been mostly associated with both childhood adversity and variation in stress-related psychopathology. When looking into candidate brain regions that are relevant both for childhood adversity and non-psychotic psychopathology, the amygdala-hippocampus region, as well as different parts of the anterior cingulate, have been intensively investigated in the context of CA, as well as psychopathology of depression, anxiety disorders, and addiction that are often categorized as stress-related disorders because of their sensitivity in relapse to external and internal stresses. Therefore, we set out in the context of an ongoing cohort called Mindset Study, measuring integrated novel dimensions in neurodevelopmental and stress-related mental disorders. This was executed at the outpatient clinic of the Department of Psychiatry and the Dolcos Institute in the Netherlands. In line with the expertise at the Dolcos Institute and the department in Nijmegen, in Mindset we included adult outpatients with a neurodevelopmental and/or stress-related disorders. So this would mean autism spectrum disorder, ADHD, mood and anxiety disorder, and/or addiction. Patients were eligible if they were 18 years or older and were fulfilling DSM diagnosis for at least one of these disorders. And as you can see on the right side of the slide, several measurements were done in this cohort. In the pre-assessment, patients filled out online questionnaires about demographics, symptomatology, and functioning. During the first session, we conducted a face-to-face clinical appointment, including a standardized diagnostic interview, physical examination, and blood withdrawal. In the second session, patients were asked to complete another set of questionnaires and perform neuropsychological tests. Data on biomarkers were gathered. The third session was the neuroimaging session, acquiring structural and functional scans. For the purpose of the current study, we looked at analysis of high-resolution structural T1-weighted images acquired at the Siemens 3T scanner. Preserver was used for cortical reconstruction and volumetric segmentation. Childhood adversity was assessed retrospectively by a semi-structured interview. The childhood trauma questionnaire was used to identify adverse life events. 165 patients, of whom 69 were female and 83 healthy controls, with a mean age of 37 years were included. The patient group consisted of 64 patients with a stress-related disorder, 49 patients with a neurodevelopmental disorder, and 52 patients with comorbidity across these clusters. A univariate ANCOVA using the factor of gender as covariate showed that when looking at both the dichotomic presence or absence of childhood adversity, as well as the scoring of all subsquares, there was a significant difference in childhood adversity between patients and controls. As is evident from the table displayed on this slide, childhood adversity was more present in patients than control and was highest in the stress-related disorders group. The main analysis revealed that an effect of childhood adversity on mean thickness of the anterior cingulate cortex, but neither an effect of psychopathology nor an interaction effect between childhood adversity and psychopathology was found. There were no significant differences in volume of hippocampus and amygdala between patient and controls. Neither did we find an effect of the presence or absence of childhood adversity. On the right side of the slide, you can see a significant negative correlation between the frequency of childhood adversity and the cortical thickness of the anterior cingulate cortex. This study has some limitations that should be mentioned. First, the assessment of various types of maltreatment during childhood was performed retrospectively by means of a self-report questionnaire. This might introduce uncertainty in the measurement, since it can be questionable to which extent retrospective reports of childhood maltreatment reflect the reality. They might be biased by the subjective experience of the witness. It has been shown, however, that adults minimize their degree of exposure on retrospective report. Thus, retrospective exposure rates are possibly lower than prospective rates. Moreover, the cross-sectional observation of our study hinders us to analyze true mediation effects of childhood adversity on development of psychopathology and brain changes across different dimensions. In sum, our study suggests that changes in a hub region for emotion regulation and psychopathology, namely the anterior cingulate cortex, is mainly driven by effects of childhood adversity. We suggest that it is important to take this into account in future neuroimaging studies investigating structural changes in different psychiatric disorders. Of course, the question that should be addressed in future studies is whether the impact of childhood adversity on psychopathology that can be found and that is not mirrored in the structural imaging findings are mainly driven by gene-by-environment interactions. With this, I would like to conclude and thank the local collaborators of the Mindset cohort as well as my co-presenters at this symposium. Thank you for your attention.
It's my pleasure to share with you our recent data. We focus on the topic of stress-induced neurocognitive reorganization linked to vulnerability. As you know, we know stress is a part of our daily life, including exposure to important interview, exam stress, and some may also experience prolonged environmental stress, such as neck parenting, especially for children, and currently like pandemic stress. So psychological stress could be a major risk factor of mental health. For example, anxiety, depression affect up more than 10 to 20% people globally. Based on the psychological and neurobiological model of stress, so we know exposure to stress can lead into hyperactivation HPA-XX system accompanied with release of cortisol. And the cortisol, so-called stress hormone, can have a profound effect, impact on widespread brain regions, then leading to changing in cognition and behavior. So we also know cortisol exists a beautiful dynamic rhythm, get high in the morning, then decline gradually in afternoon and reach its basal level in the evening. So one of the critical features called cortisol awakening response. So it's have a burst after awakening within 30 to 40 minutes. And this awakening response could be affected by both acute stress and chronic stress and major life stress as well. And we want to know whether this kind of cortisol, stress-sensitive cortisol, actually affect the amygdala hippocampal function as well as the interaction function connectivity with the prefrontal region. So we were going to show our recent data from multiple studies focus on like stress-related neurocognitive reorganization and linked to anxiety in adults and the internalizing symptoms in children and adolescents. And third part, we're going to provide the preliminary results about the causal links. So we're going to want to highlight it's like in next, I'm going to show the data and in focus on acute stress in the laboratory and also naturalistic stressors. And in the second and the third part. So for acute stress, I would like to highlight and our previous study actually found and acute stress can lead into amygdala sensitivity increased and the dorsolateral prefrontal and the function get reduced. And next, like we want to know actually whether like a long exposure to long-term stress, for example, we to have a how actually influence over prefrontal and the function and also hippocampus amygdala. And what we did is we recruit subjects and when they are prepared an important exam for almost 6 months, and then we invite them come to the lab before took the exam 1 to 3 weeks, and we have one adaptation day, and then second day come back. The adaptation days mainly reduce acute stress, and then we also perform a working memory and back task like this. What we find is subjects exposure to exam stress can have a higher psychological distress and compared to controls. And also we modeling the embedded task using drifter diffusion model in order to uncover some latent disease dynamics such as drifter rate represents the quality of evidence accumulated when they perform working memory. And what we find that interestingly, when subjects exposed to stress have a significantly higher or hyperactivation insula, and we didn't find amygdala, but really promising hyperactivation in insula. And next, it's like we want to know how actually the stress, long-term exposure to stress, actually have a vulnerability related to some kinds of anxiety. Here we made the treat anxiety. And we actually find it's like an individual with a high level of treat anxiety, they have a more like a prefrontal and also parietal IPS activation. But these subjects with higher treat anxiety and long-term stress, they have a tendency impaired of the drift rate. It means evidence accumulate when they're doing work memory task. And we test the mediation effect. What we find is a higher treat anxiety individuals under long-term stress, but not controls, actually can have a high activation in the prefrontal parietal, then get impaired like a drift rate. Okay, so this is like mediation, interesting mediation effect. And the second part is like we want to continuously want to investigate and how like a stress related neural biomarkers could be linked into internalizing symptoms like anxiety, depression, but in the developing brain. So we recruited them twin adolescent participants when they are 13 years old on average. And we take here the negative parenting as a long-term stress paradigm, and we measure them. And then 3 years later, we scan these adolescents. And what we find is negative parenting not directly linked to depression, but they are mediated by increased amygdala VLPFC connectivity in resting state. So these pathways regress out anxiety. And we test the using network-based ACE model, and the heritability actually only about 21 to 22%. Okay, this for this pathway. This means environmental effects and play a substantial role and to mediate the adolescent's depression. And then we also look into for children, those is exposure to relatively lower socioeconomic status, we call it SES. What we find is individuals from lower SES have higher parental treat anxiety and can lead into higher children's anxiety, and also can make release of cortisol. I mentioned earlier, a weakening response, cortisol lower, so it's less availability of cortisol in the body. And interestingly, we collecting subsample of these children, and what we want to test is whether this lower SES related to cortisol response. And now we actually take into not only cortisol weakening response in the morning when they wake up, but also the basal level and during sleep. So it's overall measure of the during cortisol dynamic. What we find the low SES and leading to the cortisol change, and this cortisol release actually can modulate the amygdala and dorsolateral prefrontal activation, and further can influence over hyperactivation the VMPFC when they're performing negative emotion processing. So this is mediation pathways, and we test this significant remains, and when we regress out the age. Based on this data, and we find it's like a cortisol release or stress related cortisol release, taking into account a weakening response, seems really important. So we want to next, it's the third part, we conduct two study to test the causal links. So we conducted this, it's in adults, and what we take the cortisol measure in the evening or in the morning when they're waking up within 1 hour, covering the peak and so-called cortisol weakening response. Then we scan participants 6 hours later in order to make the cortisol level it's actually go down as a relative lower level. So we split subjects according to literature. Weakening a response is get a normal robust level, but some subjects have blunt and no difference in the afternoon when they are scanning perform wake memory task. And interestingly, we find it's like subjects with lower cortisol weakening response, so less available of the cortisol and less and can provide less energy for the brain probably. And we find that need high hippocampal activation in general, regardless of task loading. And the most interest critically, we find it's like a dorsolateral prefrontal activation in the task to back or higher task demand condition actually get high for lower cortisol subjects. Okay, so they require the high level of the activation. And we then find it's lower cortisol awakening response in the morning, and then they need hyperactivation, the dorsolateral prefrontal, to maintain the wake memory performance. So we didn't observe the group difference of performance level, but the mediation effect. So next, we actually conduct a second study in this part and to test whether truly cortisol awakening response in the morning have a causal link. So then we ask subjects coming to the lab, and one day before we take a medicine like dexamethasone 1.5 milligram to them in order to suppress cortisol response in the second morning. And then we scan them in the afternoon, compatible with the first study. And the placebo group still remain at really high cortisol awakening response, but the medicine group and the experimental group will get flat. And we want to maintain the time really carefully, manipulate and make them no difference in the afternoon. Then we collecting the back task again, and the third when they come back, that's no difference. They already recovered. And we analyzing the wake memory task during fMRI and replicate beautifully dorsolateral prefrontal hippocampal from study 2 and study 1. Okay, really beautiful replication. And we have a dynamic causal modeling. Find out it's that dorsolateral prefrontal regulated hippocampus during wake memory task actually get impaired. It's a top-down effect. And this is like we think it could be when perform wake memory task, dorsolateral prefrontal should be engaged highly and should suppress hippocampal long-term function. And so this effect, so this establishes a causal link, okay? And we think it could be genomic of cortisol effect could be leading to or account for this kind of the proactive effects in the morning influence over the afternoon, right? But this assumption need further studies. So to summarize today, I'm sure some data from acute stress, exam stress, negative parenting, and SES, and we actually find it's like this kind of acute stress and long-term stress actually have a different effect on the amygdala, hippocampal, and prefrontal, as well as the interaction, okay, the connectivity. Basically, this could be linked to anxiety. We find some links and with anxiety and depression vulnerability. But certainly more studies required to like disentangle how this long-term acute and long-term stress actually affect these neurocortical pathways and linked more specifically anxiety and depression from a developmental point of view. So that's what my presentation today. I would like to thank members from our group. They work really hard collecting the data, analyzing, and writing up manuscripts. And finally, I also would like to take this opportunity to have a job posting. And we are recruiting postdocs, and I would appreciate if you know someone actually interested in this presentation, could be send me an email. And thank you.
My name is Fleur, and I am a PhD student at the Department of Psychiatry of the Radboud University Medical Center in the Netherlands. The overall topic of my PhD is self-referenced negative memory bias. And today I would like to present a project where we looked at amygdala reactivity and self-referent negative memory bias, two stress-related vulnerability markers and their relationship in a naturalistic psychiatric patient sample. Having a self-referent negative memory bias means that you have an enhanced memory for negative information, especially when it is also self-relevant. This is one of the main cognitive symptoms of depression. However, rather than just being a symptom of depression, it is also considered a risk factor or vulnerability for the development, maintenance, and recurrence of depression. Psychologist Aaron Beck developed the cognitive model of depression in the 1970s, which states that adverse or traumatic experiences during childhood could result in the development of dysfunctional attitudes or negative schemas, which might include something like, I am worthless, or I can't do anything right. When these negative schemas are activated by a stressful event or a stressful period later in life, such as a breakup or job loss, they can result in the negative processing of information, including biases in interpretation, attention, and memory. They can in turn increase the risk of developing depression. Later, biological vulnerability factors were added to this model, including genetic risk, like the serotonin transporter polymorphism, and altered biological stress reactivity, in which the amygdala plays an important role. The amygdala is involved in the detection and processing of emotional information and the subsequent memory encoding and retrieval through modulation of the hippocampus. Increased amygdala reactivity, which is the activity of the amygdala in response to a specific stimulus, often a negative one, has been related to childhood trauma, the aforementioned serotonin transporter polymorphism, and depression. It could therefore be considered an index of biological vulnerability for depression. Even though Beck proposed amygdala reactivity as a neural correlate of negative cognitive biases, including self-referenced negative memory bias, the relationship between this cognitive vulnerability on the one hand and biological vulnerability on the other hand has never actually been investigated. In addition, even though self-referent negative memory bias has mainly been linked to depression and depressive symptoms, it has also been found in other psychiatric disorders, such as anxiety, ADHD, and autism. More self-referent negative memory bias has also been linked to a higher number of psychiatric diagnoses. In one of our previous studies, we investigated the transdiagnostic value of self-referent negative memory bias. And as you can see in this figure, we indeed found that 3 groups of patients, a stress-related disorders group, including depression and anxiety, a neurodevelopmental disorders group, including ADHD and autism, and a comorbid group, including both types of disorders, all had significantly higher self-referent negative memory bias scores than a healthy control group. Self-referent negative memory bias thus seems to be a transdiagnostic phenomenon, so it is important to keep studying it in naturalistic psychiatric patient samples. So, our research question for this study was, what is the association between amygdala reactivity and self-referent negative memory bias in a naturalistic psychiatric patient sample? Our naturalistic psychiatric patient sample consists of a subsample of the mindset cohort that Indira presented during a talk on childhood adversity and gray matter changes. We were able to use data from 125 patients and 32 matched controls. In this figure on the right, you can see the distribution of the different psychiatric disorders and their comorbidities in the patient sample. To assess amygdala reactivity, we used a commonly used and robust emotion processing task. During this task, participants see blocks of scrambled faces, which we call shapes because of their oval shape, and blocks of angry and fearful faces. We used the faces versus shape contrast and extracted amygdala reactivity parameters from the left and right amygdala separately. Self-referent negative memory bias was assessed using the well-known and commonly used self-referent encoding task, or SRED. This task consists of two parts: an endorsement phase, during which participants have to indicate for positive and negative adjectives like worthless and passionate how well that word describes them. Then there is a recall phase, during which participants are asked to write down all the words they still remember from the first part of the task. The first and second part of the task are separated by a 3-minute distraction task. The SRED measures both the self-relevant aspect as well as the memory aspect of self-referent negative memory bias. And it results in a combined score ranging from 0 to 1, where 0 means that there is no negative bias and a 1 means the maximum amount of negative bias. As expected, we found significant bilateral amygdala reactivity for the faces versus shapes contrast. Interestingly, this did not differ between the patients and controls. This means that the mean amygdala response of patients was similar to that of controls when viewing negative emotional faces in comparison to the scrambled faces or shapes. When we looked at self-referent negative memory bias, we found, also as expected, that patients had significantly more bias than the controls. This means that the patient group considered more negative words as self-descriptive and remembered these words better as well. Because there were many zeros in the self-referent negative memory bias score, we looked at a subgroup of 62 patients who had a score of higher than 0. So we could look at the association between amygdala reactivity and actual self-referent negative memory bias. We found no significant relationship between both the left amygdala reactivity and self-referent negative memory bias and right amygdala reactivity and self-referent negative memory bias, even though this relationship appears to be negative. So we can answer our research question by saying that there appears to be no association between amygdala reactivity and self-referent negative memory bias in a subsample of a naturalistic psychiatric patient group. Next, instead of looking at the combined self-referent negative memory bias score that we used previously, we wanted to look at its components separately. A relatively recent study has shown that these two parts of the SRED reflect different processes. The endorsement phase reflects negative schemas, so how negative someone thinks about themselves. And the recall phase reflects memory. In that study, they found that these two processes, or two parts of the SRED, are differently associated with depressive symptoms. So we wanted to investigate whether these two different processes or parts of the task were also differently associated with amygdala reactivity. We indeed found that negative endorsement and negative recall were differently associated with amygdala reactivity. As you can see in this table, there was no significant association between amygdala reactivity and negative endorsement, but there was a significant association between left amygdala reactivity and negative recall. This means that individuals who recalled more negative words, irregardless of whether they were also considered self-descriptive, had a stronger left amygdala response to negative emotional stimuli in comparison to the scrambled faces, or shapes as we call them. we conclude that there is no clear relationship between the two vulnerability indices, so the cognitive vulnerability on the one hand and the biological vulnerability on the other hand. Our study confirms that endorsement and recall, the two parts of the self-reference encoding task, represent two intrinsically different processes. Endorsement seems less amygdala dependent and reflects negative cognitive schemas, whereas recall seems to reflect the well-known amygdala modulation hypothesis of hippocampus-mediated memory retrieval. Importantly, this seems to not only be the case in depression, but in a wide range of different psychiatric disorders. Finally, as a future direction, we should continue to better understand these two components of self-referent negative memory bias in psychopathology, including volumetric alterations in, for example, the amygdala and the hippocampus, which is something I'm currently working on. I want to thank you for listening to my talk and for the opportunity to present my research here. If you have any more questions or remarks, you can always email them to me. Thank you.